All right, this is Mrs. Blossom. She is a 57-year-old female who came in through the ED with onset AFib, RVR. She was admitted to the cardiac telemetry unit, normal, converted to normal sinus rhythm with a calcium channel blocker. Her daughter's with her, and she says that her mom is acting kind of funny. All right. Hi, Mrs. Blossom. My name is Emily. I'm going to be your student nurse today. So I'd wash my hands and introduce myself. I'd ask what's going on. If she's not able to tell me, I'd ask her daughter what's different than normal. I would get some history on her if she has any past medical history, if the AFib is normal or if that's just recent onset. Some people do live with AFib. See if there's any other cardiac history that she has. She's a smoker, if she's had any previous TIAs. So I'd go down through and I'd get some vital signs and then do a head-to-toe assessment on her. Alright, so I'm just going to get some vitals on you, okay? See if everything's doing okay. And I listened to her heart for a minute. Alright, so her vitals don't look too bad. I'd also get a temperature. Her vitals don't look too bad. I would... Okay, so then the assessments that I would, I'd want to do a head-to-toe assessment as well. So I would look at her eyes, see if they're equal and reactive. Looks like her left side's a little droopy. I'd go down through and I'd listen to her lungs. Check her abdomen. I'd listen to her lungs in the back as well. Alright. So I'd check for JVD. I'd look for bilateral radial pulses. Since she is having some facial droopiness and some speech slurring, I'd have her lift her arms up, see if, so it looks like that left side won't stay up very long. So I'd go down through, palpate her abdomen, check pedal pulses, pushes, pulls, same with the hands, and I check for lower extremity edema. So as of right now, I would assume that she is a possible candidate for a stroke. Priority assessments would be to maintain that patent airway. So I would get a suction, maybe provide some O2 until the doctor gets orders for that, since it looks like she is having a little bit of an issue. And then I would call a stroke code and get the healthcare professional here quickly, since there is only so limited time for stroke patients to get that TPA. He would have to order the CT, but I would see if he did want to order one and get those people here as quick as possible. I would also request maybe some thrombolytic therapy and maybe some fluids to help get some fluids in her. As of right now, what would be occurring with Mrs. Blossom, I would say she's having a stroke, the FAST acronym. Her face is drooping, her speech is slurred, her arms are not equal when she lifts them up in time. We're racing time at this point. So I would call that stroke code, and the doctor would come up here. All right, Mrs. Blossom, so the doctor did order the CT, and he wanted some suction, so I'll do that suctioning, and then you'll go down for some CT. So her NIH stroke scale was a 32, so he ordered a stat CT. So the suction, so I'd get some gloves on. I would observe the skin and respirations before and after. Make sure that she's still able to breathe. I'd pretend this is a suction. I'd dip the suction in normal saline or water. I'd insert it into her mouth, suction, and then I dip it back into normal saline or water. So I want to change that water every time and then I'd want to change the catheter for the suction every 24 hours, as long as she needs it. And then you can do that dipping into the normal saline and then suctioning 6 to 9 times, or as many times as she needed it. So then I would go document that I suctioned. I'd wash my hands before, I'd wash my hands after. So doctor went and took her down to CT. So after I suctioned, some other possible interventions that she would need at this time would maybe be some O2. And then I'd want to monitor that O2 stat. And then after that CT, I'd want to see if he wanted to order any meds. If he does, I'd want to administer those, and then also just monitor that telemetry since she is on that EKG. So then he did want to order some TPA, so I will go get that. That is an IV piggyback, so it'll just be hooked up to her normal saline. Some contraindications with the thrombolytic therapy, the TPA, would be an elevated blood pressure. So if her systolic was over 185 or if her diastolic was greater than 110, active internal bleeding, a glucose lower than 50, a CVA in the past 2 months, recent MI, pregnancy. If it's a minor or a quickly progressing or quickly recovering stroke, they wouldn't want to use it for that either. And then if her platelet count is less than 100,000. So I will go get that TPA. I will administer it, and then I will be back to check on her. All right, Mrs. Blossom, so the doctor did order some TPA for you, so I'm going to administer that. So before I do that, I check her wristband, date of birth, and I'd have her say her first and last name. I'd have the 5 rights: right dose, right time, right patient, right drug, and right route. Oh my goodness, it's the same thing. So I'd wash my hands, stick some gloves on. So this TPA is 0.9 milligrams per kilogram for an hour. So calculated with her body weight of 162 pounds. I believe that's what it was. Yeah, 162 pounds. She's gonna get 66.27 milligrams over the hour. So there would be a little pull here. I'd pull that off, I'd twist it up in there, spike the bag, I'd fill this up halfway, and I'd set it on the IV pump to 66.27 milligrams for the hour. So I would make sure, I'd come back and make sure that that's running at a normal rate, and the rate that's prescribed. So I would wash my hands again, and I'd go document that the time that it was, I would write on there my initials and the time that I hung it, and then I'd come back. So I administer that TPA. Some possible complications with the TPA administered, and I'd want to monitor for hypotension, bleeding, any allergic reactions. So any medication you can go into anaphylaxis from. So it just kind of depends on what each person's body can take and can't. So I would monitor for any phlebitis at this injection or the IV site. I monitor for any intracranial hemorrhage, which is a severe headache, paralysis, tingling on one side of the body, confusion, disorientation, difficulty swallowing. I'd also monitor for arrhythmias. So after 2 hours, Mrs. Blossom shows some improvement. She can hold her arms up for 10 seconds now. Her NIH stroke scale number is 6. So I would explain to the daughter that, or to Mrs. Blossom, that physiologically she was having a stroke, which is caused by a sudden drop in blood flow to the certain part of the brain. This is typically caused by a thrombus, an embolus, a stenosis, so any sort of blood clot per se. And I would explain that there are neurological deficits sometimes, so it just depends on how much of the brain is affected and how long it's without blood flow. So then risk factors would be hypertension, smoking, heart disease, diabetes, any pre-existing conditions like that, history of TIAs. So I would assume that the AFib maybe had something to do with that, contributed to the stroke, if that was a pre-existing condition prior to coming into the ED or if it was just an onset. So she would be prescribed the doctor prescribed some antiplatelet blood thinners. So she's going to go home with Plavix and aspirin. So I would emphasize the importance of taking those because otherwise that blood's just going to clot and she's going to be back to where she is now. So education that I would give her for discharge, she's being discharged. So I would educate on medication compliance and importance. So the Plavix is an antiplatelet to help reduce the clotting of her blood. The aspirin is a blood thinner to help in conjunction with that as well. Many patients who are at higher risk for heart disease or stroke do take aspirin daily. Even though it is an anti-inflammatory, it does help thin that blood. So in conjunction with that Plavix, that should help. I would also explain that she needs to follow up with her neurologist in a week as planned. That should not be optional. Monitor blood pressure daily. Consult the doctor if it's significantly low or significantly high. Diet changes. She'd want to eat less fats, less cholesterol, less sodium. Increase the fruits and vegetables and the lean proteins in her diet. And then that she would need to call 911 if she has any symptoms of a stroke again, dizziness, neurological deficit, numbness, tingling, vision trouble, severe headache, just so that since she had one, she is at a higher possibility of having another, especially if she's not taking that medication as planned. So I would emphasize the importance of all of those things, especially diet change and the medication, and then that if any of those signs and symptoms come back, that she needs to contact medical help. So other than that, I would give her, I'd go print out I document that I gave her that teaching. I would go print out paperwork for her to take home as if she forgets. Make sure that the right milligram and dosage of those two medications are on there. And I would make sure that her daughter gets her home and she is good to go. All right, Mrs. Blossom, if there's anything I can do for you, you just let me know, okay? I hope you start feeling better. Make sure you're taking that medicine as you're supposed to, okay? All right, so I'd wash my hands and be all set.